Hi and welcome to Golbalsportscare. Today I've got Dr. Lorenzo Masci with me, and we've got a quite interesting subject talking about platelet rich plasma. And obviously over the last years, platelet rich plasma has had quite a drive, and a lot of people have been using it worldwide. And we wanted to speak about the evidence behind it and what it is used for, how it works. Hello, Lorenzo.
Thanks, Marcus, for inviting me. I appreciate the invite and just discussion. I'm sure it'll be very topical, very topical discussion on PRP.
Yeah, can you just introduce yourself, what you're doing at the moment, what you're up to, interests and stuff?
So I am a sports and exercise medicine physician consultant. I trained in Australia, and about 14 years ago, I came to the UK. I was only supposed to come for a year, but now I've been there for 14 years. So my work is, I've got a very diverse work week. I work in private practice in 2 clinics. I also work in the military. I do a little bit of work in the military, and I will be working in the NHS for a little bit as well. So my work is very diverse, and I've worked in elite sport. I've done Australian football, with Fulham Football Club. I worked at Wasps Rugby for 5 years, and then also worked in rugby league in Australia for 3 years. So I've got lots of experience in elite sport and understand the pressures that you're under in elite sport. And I think PRP is very interesting because it's sort of pervading into elite sport, but maybe doesn't have the evidence for many of the things that we use it for. So we can have a good discussion about that.
That's great. So if we could start with, what is platelet rich plasma?
Okay, I've got a little presentation. So I'm going to, because this is just easier for me to explain it. So in essence, platelet rich plasma, I mean, there's nothing here that really is rocket science. All it is really just you're injecting a concentrated plasma that has lots of platelets in it. So we know that within blood itself, if you take blood, you've got different cell components. You've got red cells, you've got white cells, you've got platelets, and then you've got plasma. Now, if you spin that blood down, what ends up happening is that the heavier cells, which are the red cells and certain white cells, move to the bottom, and then the lighter cells, which are your other white blood cells and your platelets, move to the middle, and then your plasma, which is the top bit, this bit here, which really is platelet pore or cellular pore, is at the top. So what we're tending to do is with platelet-rich plasma is you're just increasing the concentration. And so what you would do is actually take this plasma away from predominantly the red cells and increase that concentration of platelets. Now, interestingly, and this is the interesting thing with platelet-rich plasma, is that you can decide whether you have a leukocyte-rich, which leukocytes being white cells, or leukocyte poor. And so there are different systems that actually give you these 2 different types of platelet-rich plasma. So each of them has a high concentration of platelets, but one group has leukocyte-rich, and then one group has leukocyte poor. So this is an example here on the left of a leukocyte poor PRP, and this is an example of a leukocyte-rich PRP. In the leukocyte-rich, what you're basically doing is really concentrating the platelets and also the white cells. So this example here is your 2 systems. So the one on the left is the leukocyte poor, and in this system, the advantages of this system are that it doesn't take very long. So in fact, you take the blood, you spin it down. The spinning takes about 5 minutes, and then or less in some systems. And then you've got some sort of product to separate. So this is the ACP system, which is really a 2 syringe system. And so what you're tending to do here is that once you've got the separation of the plasma and the red cells, you've got this other syringe that actually is able to extract just the plasma. So you throw out the red cells and then you use the plasma. And that, for example, that system concentrates plasma by approximately 3 times. Whereas the one on the right, this is the double spin. So what this does is it spins at once, and then you get this what we call a buffy coat, which contains a lot of the white cells and the platelets, and then you spin it again. So you actually spin it twice. You need to take a lot more blood, but in this case, what you can do is actually get a very, very high concentration. So in this case, with the harvest, you're getting about 8 or 9 times platelet concentration, and I think it's about 2 or 3 times leukocyte concentration. So this is a true leukocyte-rich, high concentration PRP. Problem with these systems are they're a lot more expensive. So two problems with this system is, one is you have to take a lot more blood. So normally you need about 40 to 50 mils versus 15 mils for the leukocyte pool. And the other issue is that the systems are expensive and they take a long time to do. So often in this case, you actually use anticoagulant to stop it from coagulating. And that's the other issue with PRP, is that you've got to be pretty quick when you're doing it, because if you're not, then what you'll find is that actually the platelet-rich plasma coagulates. You're not able to actually inject it into the particular target, being the joint or the tendon. So they're the two systems. Generally speaking, in the UK, we use a leukocyte poor system overall. Very few people using the leukocyte-rich system. We'll talk about the differences between the two, and particularly with the clinical evidence in a second. But overall, most clinicians and most centres will use a leukocyte poor PRP, with some exceptions. So this is really important. So how does PRP work? Well, the answer is we don't really know. However, we think that what happens is, so you've got this plasma which contains lots of platelets, and these platelets have lots of growth factors and also these cytokines which tend to be anti-inflammatory. And what we think is that when you inject this into whatever target it is, be the platelet, be the tendon or the joint or any other structure, is that these cells, particularly the platelets, act as signaling cells. So they basically tell the other cells in the joint or in the tendon to start working properly. So really the platelets are like the conductor of a symphony orchestra. So they organize the symphony and make sure that different groups are playing at the right time. So that's in essence what we think a platelet does when you inject it into the particular area. So that's how we think it works. Now, more importantly is, does it work? Is there evidence for effectiveness of PRP? And really that's what I want to know as a clinician. What am I doing? And I mean, it's important to understand why, but as you know, in sports and exercise medicine, or in medicine in general, actually a lot of times we don't really understand the mechanism of action. However, the higher level studies, certainly the randomized control trials, suggest that it has an effect. So that's what I'm looking for. And does it have a higher level evidence for its effect? So I always like comparing PRP and certainly regenerative medicine to what we have used for the certainly last 60, 70 years, which is cortisone. This is actually a very, very good paper written by John Orchard, who's a colleague of mine in Australia as a sports and exercise medicine physician. He's really summarized all the evidence for cortisone. And certainly if you look at the evidence for cortisone in knee osteoarthritis, and so obviously knee osteoarthritis is the most common sort of condition that we tend to see, certainly arthritic condition we tend to see. The results aren't fantastic for cortisone. So what are the positive results? There are 2 studies here, there's Cochrane review and also systematic review, that suggests that really it's only a short-term positive effect. In fact, out of a pain score between 1 and 10, it has an effect of just 1, reducing pain by 1 out of that 1 to 10 pain score. So it's quite a mild effect, and it only lasts for 3 or 4 weeks, and certainly you don't see any effect after 26 weeks, and that's important to know. And the number needed to treat is actually 8, which is quite high for something that supposedly is quite efficient at reducing pain. So really, it's not that great for knee osteoarthritis. It does reduce pain, but it's a mild effect and a transient effect. What about the negative effects? Well, this study's been quoted a lot. This is a 2017 study looking at cortisone versus placebo, and showing that, in fact, in the medium to long term, we don't have much positive effect of cortisone compared to normal saline. And in fact, there might be a negative effect or negative cartilage effect in the medium to long term. So we should be very cautious. Since then, that's 2017, there's been study after study, and these are cohort studies that show that, in fact, if you use cortisone, for example, in knee osteoarthritis, you may increase the risk of greater negative effects on cartilage and potentially greater effects or increasing the chances of patients going on to total knee replacements earlier. Now, these are cohort studies. Obviously, there are quite a few confounding variables. But this was interesting. This study just published recently. So this is another multi-center cohort study. So we're looking at almost 5,000 patients over 9 years. So a lot of the patients didn't have a cortisone injection. The risk was 5%. If you had a cortisone injection, that risk of having a total knee replacement increases to over 30%. What they did in the study was they used a statistical method called propensity matching. So what that does is it tries to control from confounding variables. So yes, it is a cohort study. Yes, there are confounding variables, but if you actually use these methods to try and reduce the confounding variables, there is still quite a significantly high increased risk of moving on to total knee replacement. So what that tells me is that we need to be cautious about using cortisone generally for knee osteoarthritis. I still use it. I use it for patients that struggle with pain and swelling, but I certainly wouldn't keep repeating cortisones. And as a general rule, most clinicians don't. So really, amber warning for cortisone, not that great in the short term, and perhaps we should try and avoid using it in the medium to long term. However, I still use it on occasion. So let's look at the evidence for PRP in knee osteoarthritis. Well, there have been 16 randomized controlled trials comparing PRP to other controls, that being placebo, hyaluronic acid, or cortisone. And certainly there is good evidence to suggest that PRP is superior to these controls. So this is the forest plot. So this looks at, is PRP better than the controls? And certainly on the left, and these are the effect sizes. So this is the effect or the positive effect of PRP. Anything on the left side is a greater effect of PRP. Anything on the right is controls. And certainly you can see there with this plot, you're looking at a lot more on the left side than the right side. Certainly the majority is all on the left. And this is at 3 months, 6 months, and 12 months. So certainly there's some good evidence here that PRP has a positive effect compared to these controls. Now, of course, and this is one of the criticisms I hear time and time again about PRP. It's interesting, those that criticize PRP for knee OA, don't actually look at, maybe other treatments. They're not so critical of other treatments. Of course, one of the treatments being surgery. So you criticize PRP, but you don't use that same standard for surgery. If you use that same standard for surgery, you would see that PRP actually is doing pretty well. However, there are limitations. So what is it that we don't know about PRP and knee OA? We don't know which preparation is better. So certainly I talked just previously about leukocyte poor or leukocyte rich. What the evidence suggests that maybe leukocyte poor is better for knee osteoarthritis, although we're not 100% certain. We don't know how many. So there's a trend that maybe more injections are better, certainly 2 or 3 injections. But again, we need a lot more evidence. We don't exactly know which grade is best to start treatment. It seems that maybe better with milder grades, which sort of makes sense. We don't have any long-term studies, so we don't have anything above 12 months. So we need that longer-term follow-up. And also, a lot of the studies are heterogeneous, which means that there are different sample sizes, different types of groups in the studies. And it seems that the higher the sample size, the less the effect of the PRP. So there's certainly a lot of questions, still a lot of questions about PRP. So having said that, and nevertheless, as a result of all those limitations, NICE, which is the UK, they're a group that looks at cost effectiveness of treatments. And it's interestingly, because if you look at NICE and knee osteoarthritis, they don't recommend hyaluronic acid. But NICE have actually looked at PRP evidence and said, in fact, this looks interesting. We're going to allow the PRP in the NHS with significant caveats. So they haven't approved it. They've just said we need more data. And in fact, we would like groups to do more studies. So if you want to do a study in NHS, you can, with significant caveats, i.e. Everyone is in a study. The study will contribute to this level of evidence. So you can't just sort of pick up PRP and use it in the NHS. This is a recent in 2020 study that looked at PRP versus hyaluronic acid. And again, if you just look at hyaluronic acid for PRP, you see this trend again for PRP. So PRP being on the left, positive effect on the left in those plots.
And this has been with leukocyte poor PRP.
So this is the leukocyte poor versus leukocyte rich. It would seem that there is a favor towards the leukocyte poor compared to the leukocyte rich for something like knee osteoarthritis. Now, I've spoken to some of my colleagues who say there's going to actually be some evidence coming out now that maybe leukocyte rich is showing some promise as well. So this question hasn't been answered sufficiently, and I think we just need more studies to maybe hone our PRP. It might be that actually in the future we might find that leukocyte rich is better, but at the moment it seems that it's favoring leukocyte poor. Right, so that's knee osteoarthritis. Now, interestingly, we don't have very much evidence for other types of osteoarthritis. So if you look at hip osteoarthritis, you look at ankle osteoarthritis, very, very little evidence for PRP. In fact, little evidence for injections in general. Cortisone injections, for example. The latest evidence suggests that actually for hip joints, it probably doesn't matter what you inject. And it's probably not going to be very effective for something like the hip joint if you inject cortisone or PRP. There was a recent study in the British Journal of Sports Medicine that found that there was no difference between any injection and placebo for hip OA. So we need so much more in other areas, and we can't just extrapolate. Just because it works in knee OA doesn't necessarily mean it works in hip OA or ankle OA or wrist OA or thumb OA. So it's hard to extrapolate. Right, so that's osteoarthritis. What about tendons? So PRP and tendons. So my bias, I must say, I'm biased against using PRP in tendons, and that's just based on my experiences with surgeons. I worked with Håkan Alfredson for many, many years. His bias is against PRP. I've seen lots of disasters with PRP. PRP is not an inert substance. So you inject that into a tendon, particularly a large weight-bearing tendon like the Achilles tendon, I think you need to be very, very cautious. And certainly the evidence suggests that it's probably not very effective for Achilles tendons or partial tears or tendinopathy. So that's my bias against PRP. But what does the evidence suggest? Well, this is a network meta-analysis that showed that PRP was more effective. Now, unlike arthritis, what this shows is that, in fact, for tendons, it tends to be the leukocyte rich that is more effective. This is the meta-analysis. However, lots of questions about this meta-analysis. It wasn't really location specific, so they just grouped everything together. So they just said, oh, well, most of the studies have been done on tennis elbow. Very, very few studies have been done on other tendons. So sort of suggesting that just because it works in tennis elbow, it's also going to work for glute med tendinopathy or Achilles tendinopathy. And I think we can't make that recommendation. So that's one of the issues with the network meta-analysis. The other issue is that a lot of these studies compared PRP with cortisone. Now, I mean, that's better than not having a randomized controlled trial. So these are all randomized controlled trials. However, we know that with cortisone and tendons, generally speaking, tendinopathy, cortisone is not particularly good for tendinopathy. In some cases, actually, people do worse. So if you're comparing PRP to cortisone, PRP is always going to look better than cortisone, which often drops, particularly in tennis elbow. So there's a criticism there that maybe we shouldn't be comparing PRP to something like cortisone in tendons, because of the fact that it makes PRP look better. It may not be the PRP effect, it may be the fact that cortisone do so poorly. So there's lots of debate about that. I sit in the fence. I think randomized controlled trials are good. I think you can reduce a lot of the biases with randomized controlled trials, and it's real world trials as well. So, having a placebo injection can be very difficult, and certainly recruitment can be often difficult in those studies.
And Lorenzo, in those studies, have they been around the tendon or into the tendon? Because I think this is also quite...
But generally those studies have been into tendons. Yeah, so the PRP injections for tendons generally are intratendinous, and you're targeting the pathology generally.
Okay.
It may not be in every single study, but the general principle is that you inject into the pathology, and you're trying to normalize the structure if at all possible. So I've done another example of PRP versus cortisone for tendons. So we're not looking at short-term effect, because ultimately we want a medium to long-term effect. So these are all the different tendons. You've got tennis elbow and so forth, and then you've got PRP and cortisone. So this is the evidence for cortisone and PRP for these particular tendons. So tennis elbow, most studied tendon, I think, in the body. Certainly, if you look at something like cortisone, we know that if you give someone cortisone for tennis elbow, generally they do worse in the medium term than if you do nothing at all. So, people argue about this. Is that harm or not? Because in the end, they get better probably. So is there any harm in actually just injecting cortisone into tennis elbow? My argument is probably I would classify that as harm. I mean, if you're saying that they actually do worse overall in the medium term, then probably not in your interest to inject cortisone for tennis elbow unless someone's really, really struggling with pain, because we know it works in the short term, but not so much in the medium term. Now, if you look at PRP, in fact, there is some evidence for this. A little bit controversial. So there have been 2 systematic reviews and meta-analyses, and there have been 2 that have shown positive effect and 1 that's been shown a negative effect. So there's a little bit of politics here, and if anyone's interested, they should look into that. If you look at the British Journal of Sports Medicine, they published that negative systematic review, and I would argue that there were some letters to the editor following that. So if anyone's interested, if anyone's a tendon geek or wants to look at the controversies, they can look into that. But it's quite interesting. I think for me, I would say there is evolving evidence for use of PRP for tennis elbow, and I think that look at this option rather than an operation. And certainly, if you look at operations, there's no difference between surgery and placebo surgery for many of these tendon pathologies. So I certainly still would use PRP for tennis elbow. So what about plantar fasciitis? So cortisone certainly, like most tendons, what we find with plantar fasciitis or plantar fasciopathy is that it only has a short-term positive effect. So one study showed that it was only like sort of 2 or 3 weeks of pain relief for cortisone. And in fact, this study here was a cohort study, so not a great study, but there were some concerning trends in that 50% of patients that had a cortisone injection had pain after 9 years, still had pain after 9 years. Now, is that the cortisone or the fact that they had a problematic plantar fascia? Don't know, but certainly you'd have to question that and go, well, 50% of patients that had cortisone injections still had pain at 9 years. That could be a bit of a problem. That could be associated with cortisone. It may not be, but it could be. So we need to question mark there and question whether we need to do that. Now, again, for PRP, there is some actually really good evidence. Well, I wouldn't say really good. I would say there's some evidence that PRP is definitely better than cortisone. There's no doubt about that. So randomized controlled trials comparing PRP to cortisone, PRP is definitely winning out in the medium to long term. And this is something that I've changed my practice in the last probably year to 2 years, is actually recommending, to my plantar fasciopathy patients who are really struggling and maybe have had a cortisone injection and not really getting better, that maybe the next step after having tried all the other treatments is maybe a cortisone rather than going on to have surgery. And we can chat about that, but that certainly have changed use of PRP, and I'm starting to use a bit more PRP for these patients. What about gluteal tendinopathy? Similar sort of process with cortisone. Really don't have enough data. 20% success in this study by Fitzpatrick that I'll mention in a second. For gluteal tendinopathy, again, for PRP, not enough data. I'll talk about the Fitzpatrick study, which is quite a good study in a second, but not enough data. Achilles and Patellar Tendinopathy, cortisone, certainly I wouldn't use it personally, cortisone for Achilles and Patellar tendon. I think there's a high risk of quite a lot of harm. You've got large weight-bearing tendons, potential for rupture. I've seen lots of disasters with it. I just wouldn't touch, personally, I wouldn't touch an Achilles or Patellar tendon with cortisone. I just think the risks are too high. And again, for PRP, we don't have enough data. There is some evidence maybe coming out that PRP for Patellar tendinopathy might be positive, although there was another study recently that showed it wasn't. I personally don't use it for Achilles tendinopathy. I don't think it works very well. I think there's potential for harm. Lots of people using it though. I just had a case last week of an elite athlete that, you know, they were going to put PRP into the tendon. I'm like, I'm not sure that's such a good idea, even for what they think is a partial tear. You know, lots of people are using it. They don't say they're using it, but certainly they're using PRP. Rotator cuff pathology, again, cortisone, not enough data, probably transient improvement, not enough data for rotator cuff. And then for de Quervain synostonovitis, again, we don't have very much data on medium-term outcomes. It seems that for de Quervain's and trigger finger, generally, cortisone works pretty well in the short to medium term. Whether that has a negative effect or not, we don't know. And certainly we don't have any evidence for PRP. So that's the evidence for PRP. So you can see the tennis elbow and plantar fascia are probably my targets at the moment. The rest I tend to be very wary of.
And
this is
to the plantar fascia and the tennis elbow. Again, were this studies with 3 injections in weekly intervals, or were there variety?
So I'm not 100% certain how they've had. I think there was a couple of repeat injections, not that many though. I don't think they had too many repeat injections. So I think this is the problem with the studies, is that everyone does it slightly differently. But overall, if they group results together, it seems that PRP is definitely better than cortisone for tennis elbow and plantar fasciitis. I think the answer to that, you know, how many times should we inject, we don't know. We can chat about that in a second if you want to. This is an interesting study. This is a colleague from Australia who did a very good study, and this study's been trashed quite a lot. I think part of the reason why it's been trashed is because people didn't like the result. But in essence, what it shows is that if you got gluteal tendinopathy, and big problem gluteal tendinopathy, as you know, Marcus, see lots of patients with this. So she did a study, James Fitzpatrick, very good study, failed rehab, patients who had clinically diagnosed gluteal tendinopathy, randomized into leukocyte-rich. So this is where you've got the double spin, leukocyte-rich PRP versus cortisone. Patients didn't know what they got, whether they got the leukocyte-rich PRP or the cortisone. So everyone got blood taken, and then it was just randomized into whether they had cortisone or not. And here you can see statistically significant difference occurring at about 3 to 6 months. So you see this breakaway of the PRP, and this is the modified HIP score. So you get sudden improvement, and then this is maintained at 2 years. So you get this significant improvement, and then it's maintained at 2 years. So success rates for cortisone about 20%, for PRP about 80%. So this is really quite interesting. And again, one of the criticisms was, well, they compared it to cortisone. That's fine, but it doesn't negate the fact that the PRP increased significantly, as you know, compared to the cortisone. So yeah, it makes the PRP look better, but in fact, these are patients that have rehab already. So the criticism there was, well, there's no natural history. Well, these patients probably have already struggled for at least 6 months anyway. Were they going to suddenly get better after this treatment? Maybe, maybe not. This could be placebo related, obviously, this effect. But certainly there's promising positive effects for PRP. Very interesting study. I think we need more studies like this. Yeah. And certainly maybe my criticism would be, if you use a placebo, what's a placebo? I mean, you could use normal saline. We know even that has a placebo effect, but you could use something like normal saline and show that if you get this similar effect, show that actually it is the PRP and not the the placebo effect. So with PRP, I can accept that there are some positive effects, positive studies. There's some, maybe we need more studies in certain areas. What I don't accept with PRP, and this is my direct criticism, is this now move by usually pharmaceutical companies and also practitioners that obviously want to make a lot of money, is moving into these areas where you modify the PRP and call it, a enhanced PRP, or we'll get into stem cells in a moment. But this is called eStride. So this is certainly becoming more popular in the UK. I'm not sure whether it is in Switzerland, but people are marketing eStride. I've actually had it done myself because I teach on a PRP course, and we had eStride there, and I was the guinea pig because of COVID. We couldn't get patients in. We normally get patients in. So I actually had the eStride done. So this is a double spin. So it's leukocyte rich PRP, but actually there's a third spin as well. So it's 3 spins. So they take like 50 mils of blood and they spin it down, and literally you're left with 3 or 4 mils, very, very high concentration leukocyte and platelets. And this third spin supposedly is supposed to, these are the tubes here that you put it into. Supposedly it's supposed to tilt the balance between cartilage synthesis and cartilage degradation. Again, no evidence for that. But if you look at their studies, it's very interesting. This is a study they did looking at N-stride versus normal saline. So this is the placebo study. And they found that in fact there was no significant difference between the groups until 52 weeks. So it took 52 weeks before there was a positive effect. So that's quite interesting. What happens after then, we're not sure. So they've got this 12-month data, and they're marketing it, and they're charging about £2,000 for an injection when they've got only data that suggests at 12 months you get a positive effect. Now,
this is in knee osteoarthritis, or what?
Knee osteoarthritis, knee, yeah. Now, I understand why they're excited about this, because if we can show that just one injection gives you 2 or 3 years relief, then it's probably worth your time and effort to have this done, and maybe even your money, because they've got some case series that show that actually people get relief for 3 or 4 years. So it's exciting, but I think we need the studies to show that it actually does work, and it's because of the N-stride rather than because of placebo effect. If I'm paying £2,000, I'd want my injection to work. Actually, my knee is better. I had the injection. It feels fantastic. But hey, when you have eStride, you want it to be better. So I've got a bit of arthritis in my knee. Well, it's a little bit. I've got a bit of patellofemoral pain or arthritis. So it feels a lot better. I can do heavier squats now. So that's really good. I'm very happy. But we need the evidence. And then we're talking, now this is a whole different field. I'm going to very briefly go over stem cells, very briefly, just the principles. But now, again, this is one of my criticisms. Rather than going, okay, PRP, there might be some evidence here. We're working with this. We need to find out exactly what works. So people have gone, oh, we need to go into different injections. So, they're taking bone marrow. So we know bone marrow has high numbers of platelets and white cells within them. So, orthopedic surgeons and other practitioners are taking bone marrow and injecting it. They're taking fat. So we know that fat contains a lot of cells, and these cells are called periocytes. They're not stem cells. So we call these stem cells, but they're actually not stem cells at all. They can, if you grow them in a test tube, they can move on to different cells. But if you inject them into a joint, what they do is they signal like a platelet. And so really you're just putting in these signaling cells, which supposedly are a lot more potent than the platelets. But again, we don't know that. So you can take fat, you can have a nice liposuction, get rid of my middle-aged spread, at the same time inject my knee, feel fantastic. You can take amniotic fluid, so from fetuses, you can take that has a lot of pericytes in it, or what we call stem cells, or the placental cord, and people inject that, they process it and inject that into into knees. This is all happening primarily in the United States, also happens in a few other areas. But if you look at the evidence for stem cells, again, we have very little evidence that actually stem cells do anything. The only study that was done was actually the Mayo Clinic that found that if you comparing bone marrow aspirate, there's this one here, to normal saline, there was no difference between the two. So they both improved. So, you know, really there's no evidence that stem cells are better. But you've got this proliferation, you've got companies in London. I'm not sure in Switzerland, do you have companies injecting stem cells?
No, nothing I'm aware of. There are a couple, but it's not as highly promoted as in London. But
yeah, I mean, London, you've got like probably about 6 or 7 at least that are directly promoting it, and then you've got a few others that are starting up. And again, we have no evidence that actually injecting these periocytes or stem cells, they're not stem cells really, do anything better than just injecting PRP. In fact, we don't even have any evidence that injecting these is better than PRP. They've got some case series, but nothing randomized at all. So obviously need that, and certainly we're looking at a cost of upwards of £7,000 or £8,000 for, say, something like this, where you're taking fat and you're processing it and then injecting it. That's often done at the same time. So I've seen it done. You go to a theatre and you have liposuction. Plastic surgeon does that. Then someone processes the fat, and then that fat is then injected within half an hour, and you can inject it in different body parts, you know, joints, tendons, whatever. Face, you can have your face done as well. so you can have it all done at once. You have liposuction, plastic surgery. So yeah, it's very controversial, and it makes me uneasy when I see this, because the evidence isn't there. But so in summary, with PRP and evidence, if you're looking at evidence, reasonable evidence for knee osteoarthritis, some evidence for tennis elbow and plantar fasciopathy, with the caveats that a lot of the studies are not so great, and probably not much evidence for anything else. And that includes other joints, other tendons, and certainly other musculoskeletal issues. So we're talking about ligaments, muscles big in elite sport. I know that, you know, athletes have PRP injections into muscle tears. I'm not sure I understand the rationale. You've got a tear which is bleeding, and then you inject, in essence, what is plasma, blood, into there. It probably not going to do any harm, but probably not going to do any good either, apart from placebo effect. And recent systematic review suggests that it probably is no better than a control. So I'm not in favor of it personally.
What I've been reading is also the long-term question is if it causes fibrosis and actually increase scar tissue. So
oh yeah, I mean, that's definitely possible, because what you're doing is you're injecting a signaling substance that potentially might overcompensate, and you might have more, you know, the body might sense it as more blood, and so you get this fibrosis occurring, and actually it could make things worse. We just don't know.
Well, so I think, you know, that was a fantastic overview, Lorenzo, and great that I had your time. And from the evidence, obviously, we're still, I think, at a time where more evidence probably will need to be generated in this area. But
yes.
Obviously, for people listening, I think for knee osteoarthritis, the evidence seems to be emerging quite good.
Yeah, I mean, I think so. I get asked this all the time, and on my website, there's actually, I've got a blog that explains it all, and just in layman's terms. And I'm upfront with people. I just say, look, if I had knee osteoarthritis and I was struggling, and I didn't want to have an operation, a knee replacement, because if you look at the other evidence, what's the other evidence for knee osteoarthritis? You've got, I've mentioned cortisone, which is not fantastic. Exercise therapy has the best evidence. We know that. But some people struggle, so still struggle to try and keep fit. And I think, you know, if you're looking at a substance that gives you a bit more longevity, then I think PRP is a reasonable substance, but has to be combined with those other treatments: weight loss, exercise therapy, improving, you know, your diet, basically just a healthy lifestyle. And I think if you combine those two, I think, and certainly I think it has a positive effect. For tendons, I'd be cautious about using it personally in large weight-bearing tendons like Achilles or Patella tendon. I'm not such a fan. But I think for tennis elbow and plantar fasciopathy, you could probably make an argument for using it there. What do you use it for, Marcus?
Mainly knee osteoarthritis, yeah.
Yes, arthritis, yeah. And anything else that you use it?
Plantar fascia and also tennis elbow. But if you look also, there are some comparable studies for tennis elbow which actually compare autologous blood, so just taking venous blood with PRP, and there was not much difference. So, and obviously it's a cost implication even here in Switzerland. So that's why, obviously, like you, I explain it to patients, and yeah, it's a joint decision making. Yeah.
Yeah, I think so. I get criticized for promoting it. I'm not promoting it at all, actually. And it's interesting, the criticisms that I receive from some people are quite interesting, because I often find out subsequently that they use PRP for lots of conditions that I don't use PRP for. So, or they use other injections, dextrose or sclerosants or high volume that I think are not particularly useful. So I get criticized for promoting it, but then I find out that actually they're using injections for something that doesn't have a lot of evidence either. So it's just one of these things that I think you just become comfortable with what you're using. I think that's reasonable. And I think we just can't have a very, we've got to have an open mind as well, and not be very dogmatic with what we think works and doesn't work. And I think we need to be, the other thing is you need to be cautious. I think that's important.
And I think that's something I took actually today from your presentation and stuff. It's always about also reducing the risks. So, and if you compare steroids with PRP, then you probably knee osteoarthritis or these tendon indications we talked about probably better with PRP. But then the question is always, it's also the insurers. I think a lot of us or will actually decide what is paid for by the insurance company, and that's something which needs then communicating. And I think that's one part of this.
Yeah, I mean I think that's a little bit unfortunate, because insurance companies will cover cortisone injections for tennis elbow, for example, but they won't cover PRP injections for tennis elbow, even though the evidence suggests that cortisone causes harm. They'll cover 3 cortisone injections for subacromial pain, but they won't cover anything else. So it's quite interesting. They're set on stamping out PRP, certainly in the UK anyway, rather than having a more balanced approach. And I think I think their view is if they open the floodgates, it'll all just happen. But that, as you know, insurance companies can actually put stops on this. They can say, well, we're only allowing a couple of PRP injections, or or one hyaluronic acid, so they can do that. They can put limitations on it, but they've chosen not to. Just said no.
Well, the thing is, obviously, what is the other option is surgery, which is more expensive.
Exactly. Yeah.
Great discussion, and I think we could speak about this probably for ages.
We could speak on for forever.
I thank you for this great introduction to PRP, and I'm sure we will discuss it at some point again.
If anyone has any questions, happy to answer them. If you just go on my website, www.sportdrlondon.com, if you can ask me a question, if you can contact me, and there's blogs on PRP and different injections as well.
We will put a link underneath this.
Perfect.
Okay.
Okay. Thanks, Marcus.
Bye-bye.